Good morning, class. Today we're going to be covering chapter 7, which will be the skeletal system. For this portion of the lecture, we're going to primarily focus on the physiology aspect of bone and talking about bone formation. We're going to talk about something called hematopoiesis, which is red blood cell production, as well as we'll also be talking about some pathological issues like fractures. So to start off with, when we think about the skeletal system, we're thinking about the major organs, which are going to be bones. And if you think about bones, again, now knowing that they're an organ, we know they're made up of multiple different types of tissue. So we can think about they're not only being bone tissue, the idea of like compact bone and spongy bone, but there's also cartilage, dense connective tissue, as well as blood cells and nerves. So many different tissues are going to be composing bone. And when you think about bones, they are living and they have many different functions associated with them. First thing that we think about is they help us to provide framework, so they're good for support. They also provide attachment for muscles as well to allow for movement to take place. And they obviously protect our tissues and our different organs. So if you're thinking about the skull, there are several bones within the skull that are going to protect the brain. We have vertebrae to protect our spinal column, our spinal cord. If you think about your rib cage and your sternum, that's to help protect the lungs and the heart. So they help to actually protect our softer tissues. Another big thing too, again, when we think about compact bone, that's the tough, more durable aspect of bone. But within bone, we also have something called spongy bone. And spongy bone actually has these little trabeculae that allow for true blood producing cells to occur. And that's when we're going to start talking about something called hematopoiesis, which is the formation of blood cells, not just red blood cells, but the formation of all blood cells. And then they also help us to store inorganic salts. So we think about calcium as being one of the ions that's stored. We're going to also talk about something called hydroxyapatite, which is a mixture of calcium and phosphate, but we're also going to find other salts within bone as well that are going to be stored there to allow for durability and strength. And so we will be talking more about that here later on. When we talk about bone structure, it's kind of something to think about that, again, bones are going to vary in their size and their shape. So obviously the bones in the skull are not going to look like the bones of your femur, of like your thigh bone, but they do have some similar features. The big thing is that how they're structurally composed. So again, they are going to have this compact bone, this spongy bone. They're going to be made up of the same different types of cartilage to bone cells to create different tissues. And again, they will have blood vessels and they'll have nerves. So structurally, they're pretty similar. Development can vary, but for the most part, it's pretty similar. We're going to talk about two different types of development of bone. And so we'll be mentioning a little bit more about that later on, about depending on where it's formed. There could be endochondrial or intramembranous ossification taking place for development of bone. And again, they're similar in their function, but they do vary in their size and they vary in their shape. So thinking about classifications in terms of their shape, there are 4 major classifications, but I'm going to introduce sort of a 5th idea. So be prepared that there are 4 different classifications, but we're going to be actually talking about 5 different names. So when we classify like the femur or the tibia and the fibula and the humerus, those are what we consider to be long bones. And so long bones will have this very narrow shaft. We refer to this shaft as something called the diaphysis. And you'll notice that it has these expanded ends, which we refer to as the epiphysis. And so, like I said, the humerus, the femur, tibia and fibula, radius and ulna, those are all long bones. Then we think about short bones. And down here in this figure here, we're looking at the tarsal bones. So usually short bones tend to be like cube-like. And again, they have a little bit more width to them, or it's, the length is about the same as the width. But we can also include within short bones a certain type of bone. And this is where the patella, the kneecap as we know it, we'll refer to it as the patella from now on, comes into play. This is a type of sesamoid bone, or also known as a round bone, not circular. It's either sesamoid or round bone, but they're under that classification of short bone. But if I was to ask you, the patella would be classified as, I'd like you to know that it is a sesamoid bone. And usually these are embedded in tendons. So when we talk about tendons and ligaments link bone to bone. Ligaments are like ligaments, they link bone to bone. Tendons link bone to muscle or muscle to bone. So that's kind of a good way to remember them. Now, if we look at flat bones, for instance, we can see many in the skull, or like if we were thinking about like the sternum. They're more plate-like and they have these broad surfaces to them. So when we look at this portion of the skull, this is called the parietal bone. And again, you can see that this portion here is flat and then it has these broader surfaces around. And then we have bones that just vary in their shape. So if you think about like your vertebrae, for instance, your thoracic vertebrae, this is an example of an irregular bone. So usually they are connected to several other bones when we see them. And again, they just don't fit into these other classifications. All right, now getting into a little bit more detail about a long bone. So as I told you before, when we think about long bones, we think of usually like our extremity bones, so our humerus, radius, ulna, tibia, fibula, and then of course the femur. And so this picture here that we are looking at is actually of the femur. And so when we talk about the shaft of the bone, that is what we refer to as the diaphysis. So we can see that here. And actually I'm going to highlight it in green. This is the diaphysis. So this is the bone shaft versus the ends are the epiphysis. And so it will have two ends to it. And then what we will see within the epiphysis are these plates right here called the epiphyseal plate. But we know them as a different name. We actually refer to them as growth plates. And when you go to see these growth plates, they're actually going to have hyaline cartilage within them until you're about age 25. Then this is completely ossified, and instead of calling it the epiphyseal plate or the growth plate, we refer to it as the epiphyseal line. So depending on age, and if you were to look at an x-ray, you would be able to identify whether it was a young kid or an adult based upon those growth plates. Now, there is also something called the metaphysis as well. So that's just kind of like the middle portion, and then it's kind of like the widening part when we think about those expanded ends. I will not test you on that portion here. So I make mention of it, but I will not test you on it. What I will ask you about though is the articular cartilage. So this is a cartilage that sits on the ends of the epiphysis. And so we can see this right here. This is called the articular cartilage. And this is actually where we're going to have joint interaction. So between bones, because we don't want to have friction, we're going to have some sort of joint. When we think about joints, some of them are going to be movable, some are slightly movable, and there are a few that are immovable that they just don't move at all. However, obviously, like with the femur, we know that their interactions are going to have movable joints. We call them synovial joints. And so there's this cartilage around there to allow for that joint to sort of settle in. We'll be talking about joints in chapter 8, so be prepared for that next week. You will see that articular cartilage come back. Now, in terms of when we speak about bone, some things to know are from Greek and Latin terms. So if you see the term oste refers to bone. So like osteoarthritis would be the inflammation of the bone and joint. If someone had osteitis, they're having issues within their bone. Or if someone had an osteotomy, they had something taken out of their bone. Now, the term periosteum, peri means surrounding, and then oste means the bone. So if we look here, we're going to see that there's this covering over the bone referred to as the periosteum. And so what will happen is the periosteum is sort of this outermost layer. And then what will happen is deep to that is you are going to have the compact bone. And again, the compact bone is nice and tough and hard. It creates the walls of the shaft or that diaphysis. And again, when we look at compact bone, we can see it's nice and tough and dense versus spongy bone is not. Spongy bone is what we see here. And it makes up the epiphysis, as well as you can see part of it in the diaphysis for this, what's called a medullary cavity. But when we look at spongy bone, the reason it looks like a sponge is because instead of being nice and dense and all like one cylindrical piece, it actually has these little bony plates within them, or to me, they look like little holes. They're referred to as trabeculae, and that's what makes them look like a sponge, is they have these bony plates, and it makes it kind of look more like sponge. Now, this is actually kind of perfect because with compact bone, again, if you think of structure, it's nice and dense and weight bearing, and it gives that sturdiness to bone. But if you had your bone be completely composed of compact bone, it would be very heavy. And so the spongy bone allows for a little bit more of that lightening of the bone, as well as it allows us to store salts and be able to have our red bone marrow within there as well. So again, with structure comes function. Now, if we look at the shaft, or back to that diaphysis, we're going to think about something called the medullary cavity. So you have this compact bone, then you have this medullary cavity within. And when we look at the medullary cavity here, I'm going to show it in black, you're going to see that it's sort of like this, like hollow chamber. And within there, we're going to have our marrow. There will be a mixture of red bone marrow and yellow bone marrow composed within there, as well as you can see all these blood vessels actually running to the bone. Bone is extremely vascularized, which is great. Allows for healing, allows for lots of nutrient growth, and it allows for homeostatic balance too. So very much needed that this bone has lots of blood vessels. But in that medullary cavity, again, it contains yellow marrow as well as red marrow. Yellow marrow helps to store fat. Red marrow helps with blood cell production. And we'll be talking more about that here later on. And then what we'll also see as well as this endosteum, and that actually lines the medullary cavity. So when you go to look at these layers, like I said, you're going to see that there's this periosteum. That's kind of like this outermost layer. Then you have compact bone, which is nice and tough and hard. Then you're going to see this endosteum. So it kind of like sandwiches the compact bone. And then within there, again, we find our medullary cavity. So a couple different layers to be starting to think about. And then, like I said, when it comes to the bone marrow, it can be red marrow or yellow bone marrow. And so that's one thing that we want to make sure you know. The yellow marrow helps for storage of fat versus the red marrow is going to help for that blood cell production. All right, now if we were to look at a microscope slide, you would see that we have these bone cells called osteocytes. And I do need you to know the difference. We're going to talk about the terms osteoblast, osteoclast, and osteocyte. I do want you to know the definitions for all three. So make sure that you are well aware of the difference between an osteocyte, osteoblast, and osteoclast. We're going to talk about osteocyte right now, and then we'll bring up the other two in just a moment. But an osteocyte is a mature bone cell. This is the guy that's keeping up the day-to-day maintenance. So fully formed, not changing, going to keep up bone maintenance. And so what it does is it actually sits in this little chamber called the lacuna. And I do want you to know this. Lacuna is singular, lacunae would be plural. So these osteocytes sit in these chambers. And if you look at this picture here from this microscopy slide, you can see that the cell has these processes that come off of them. They're called canaliculi. And these processes are going to be able to actually move nutrients back and forth like little passageways. And so again, it allows for different osteocytes to exchange these gases and nutrients and waste products by these little passageways, these little processes. And they are again called canaliculi, which is a very funky term. Now, when you think about bone, so again, we have bone cells, and our bone cells are the osteocytes. Now, everything around it is called the extracellular matrix. So thinking back to when we talked about tissues and we talked about connective tissue, you have your cells, and anything around the cells is called extracellular matrix. When we think of the matrix of bone, there's a lot of collagen fibers. So I want you to think about why there would be collagen fibers. Think back for what collagen fibers do. They give the bone durability and resilience. So it makes that bone a little bit stronger, a little bit tougher. As well as, again, we also have inorganic salts that help to make the bone hard. So collagen gives the resilience, again, allows for that durability, and the salts make it hard. So when we think about compact bone and why it's hard, we have inorganic salts there, we have collagen fibers, and that's what makes it very strong and very durable, and can take a lot of pressure. Now, this is a great picture to be able to see these vast differences. So in the figures below, it gives you a description of that compact bone versus that spongy bone. So the picture at the top just makes it so much easier to see. This portion here is your compact bone. And when we look at compact bone, it actually has these cylindrical units within it. So if we think back to like our microscope picture that we learned a few weeks ago, you've seen that there was like these circular components, and it kind of looked like a piece of wood when we seen it. Those cylindrical units are called osteons, and they have these layers around them called lamella. And then right in the middle is a canal, and that canal contains blood vessels. We refer to it as the central canal. So that's why it kind of looks like a piece of wood when you go to see it. Now remember, you also have like these osteocytes that are kind of just hanging out here in those little lacuna. And again, they're the ones that are doing the day-to-day maintenance of the cell. So make sure you know that compact bone consists of osteons. That is a very important thing. So when you think osteon, think compact bone. Again, strong and solid, weight bearing due to those collagen. And again, it's going to be strong and hard because of those inorganic salts, and it helps to resist compression. So this is why we're able to jump and we're able to run, and we have all this, a lot of weight bearing exercises done, and compact bone kind of comes in to save the day. Versus spongy bone has these plates, and these plates are what we call trabeculae. And you can see them really clearly in this picture. Again, depending on the pictures, you can see those trabeculae a little bit stronger. So I would say figure A is a little easier to see. This allows for flexibility. And again, it helps to make sure that the bone is not heavy. So you can actually move your bones without having that struggle. So it kind of lightens it up, allows for flexibility, helps to reduce that weight, as well as we're going to have lots of nutrients, and we're going to have our marrow actually reside in there as well. So with structure comes their function. All right, now getting into more detail about that compact bone. So again, compact bone, if we look back to that microscope picture that we looked at a couple weeks ago, when we were talking about tissues, we've seen that it looks like wood. This is compact bone that we're actually looking at. And again, when we think of compact bone, think about these osteons, these cylindrical units that you're able to see. And so there's several osteons within compact bone. It's not just one, there's several osteons that compose the compact bone. But within the osteons, you see these cylindrical units that are called lamellae. And then there's right in the middle, let me do it in black, this central canal. And within this central canal, you find blood vessels and you find nerves. So something very important to think about. And what happens is that they have their own set of channels that run between osteon to osteon. And we call these perforating channels. So they join all the canals together. And again, this allows nutrients to go to bone tissue as well to pick up waste. And like I said, those osteocytes, which we can actually see very well in these little pictures, these little dots that kind of look like ants. If you were to zoom in and look at it, you can actually see how those osteocytes have those processes called canaliculi that also allow for the osteocytes to pick up that waste and nutrients. And like I said, and then it runs through the central canal, and you have different channels that are running them together, and it kind of all works to get nutrients to the bone and get rid of the waste product. So that's what you're going to see in terms of the osteons. And I also like this picture here because this allows you to see that periosteum that's actually surrounding the entire bone. Now, when we think about bone development, there's going to be parts of the skeletal system that start developing in utero. So when a female is pregnant, she will go through this prenatal development. And so when we think about these structures, they're going to grow not only in utero, but they continue to grow once that baby is born, and they will continue until adulthood. We usually say by age 25, all bones have ossified and that person is no longer going to have bone lengthening. They can have bone thickening, but they will not have bone lengthening, aka you won't get taller past 25. So again, on average, some people, again, maybe blossom a little bit, older, or some maybe did younger, but usually by age 25, we're done with that growth. And so when we think about how the bone development occurs, there's actually two different forms. And what is happening is that we actually have bone being the new piece, and it's actually replacing connective tissue. So again, there's two different ways to look at this. This could be either this intramembranous ossification or intramembranous bones, or it could be endochondral bones and endochondral ossification. When we think of intramembranous bones or intramembranous, whatever way you'd like to say it, usually these are the bones of the skull. We have a couple facial bones that we look at as well as like the sternum too. So they are more of those flat bones. Versus endochondral bones tend to be the bones of your extremities that are going to undergo this transformation. So they're originally starting off as some other connective tissue, and then they move their way to being replaced by bone. So let's talk about those two different mechanisms. So again, this is looking at a 14-week fetus in this picture. We can actually see how we have bones forming in both aspects. We have the endochondral bones forming, as well as the intramembranous bones taking place as well. So again, usually when we think of the bones of the skull, the clavicles, the sternum, we're thinking about intramembranous ossification. And this is actually going to be forming sheets of primitive tissue. And we call this primitive tissue mesenchymal tissue, or sometimes the book will refer to it as just primitive connective tissue. And again, it will be replaced by bone. And then endochondral ossification, we start with hyaline cartilage, and then that will be replaced by bone. So I would like you to know where are some examples of these bones and what is being replaced. So in intramembranous, you have mesenchymal cells or primitive connective tissue being replaced by bone, versus endochondral is hyaline cartilage being replaced with bone. So the first thing that we're going to talk about is this intramembranous. So again, up at the top, I have some examples for you to think about. And what is happening here is this is the process of replacing that embryonic connective tissue to form your bone. So as I said, in this connective tissue, we have what are called mesenchymal cells. And they are going to differentiate, meaning they're going to convert or change into what are called osteoblasts. Now, recall just a few minutes ago, I told you need to know osteoblast, osteoclast, and osteocyte. So here we're going to talk about osteoblast. The way I always remember blast is I think about baby. Blast equals baby. So these are like the baby cells. And really what they do is they allow for bone formation to take place. So osteoblasts are bone forming cells. And what they do is they lay down bone matrix around themselves. So imagine that this is your osteoblast and it starts laying down this bone formation around itself. Now what happens is that osteoblast gets trapped in these little lacuna, and then they actually are going to mature into osteocytes. So if you think about blasts as baby or bone formers, that's the way to sort of think about this. And when we talk about osteoblast's job, they're used in bone deposition, meaning they're depositing bone formation and they're going to be basically making bone. And when they are now completely surrounded by this matrix, again, they now are going to do their final conversion to osteocytes. They finally mature into these osteocytes, which are the normal mature bone cells. And remember that they lay in those chambers called the lacuna. And then what's going to happen is this mesenchyme that's on the outside of the cells actually starts to form what's called the periosteum, that outermost covering of the bone. And it starts to just sort of work its way in. So when you get to see these pictures, you can sort of see how this is going to form. So again, you have your original mesenchymal cells. Sometimes they're also referred to as the progenitor cells. And we can see this ossification center taking place. So we can see where those osteoblasts are coming to work. And they're laying down this bone formation around themselves. And then, like I said, as this happens, they get trapped and they mature into osteocytes. And this just continues on and continues on. And eventually what ends up happening is you don't have that mesenchymal cells anymore. You're now forming that periosteum. And then from there, it'll keep continuing and we'll have that formation of spongy bone as well as compact bone. Versus endochondrial is a little bit different. So endochondrial is going to be replacing hyaline cartilage with bone. And yes, I do want you to know that it's hyaline cartilage. So if you recall with hyaline cartilage, they have these chondrocytes, which are cartilage cells, and they also sit in little spaces called the lacuna. So we see all these like chondrocytes around. And again, they sit in their own little spaces called the lacuna. Now, what happens with these guys is they actually have like a collar around them. So imagine, if you will, that there's like this collar that's around these cells. And we call this the perichondrium. So it's covering these cartilage cells. When we think about endochondrial bones, again, these are going to be like your long bones. We also think about your phalanges and we think about your vertebrae here as well. But what's going to happen is you start off with hyaline cartilage. And remember, hyaline cartilage has cartilage cells called chondrocytes. They start off a little bit smaller and then they enlarge. And when they enlarge, that lacuna starts to grow. But what's going to happen is the matrix that's surrounding the chondrocytes starts to break down. And the chondrocytes actually die. When they die, they basically calcify. And so what's going to happen is now this will allow for opportunities for osteoblasts to go into that area. And so where there's this calcification, they start to lay now this groundwork for that bone matrix. And what's going to happen is these osteoblasts actually, again, become trapped. And then they are going to sit in these spaces called lacuna, and then they are going to differentiate into your osteocytes. Now, what's also going to happen as well is, again, when these chondrocytes die, we also are going to have blood vessels that are going to grow into the perichondrium, that stuff that's around the cartilage. And again, they convert to osteoblasts. So the shaft becomes covered with basically the superficial bone. And the more blood supply and osteoblasts that go to the area, they start to produce spongy bone. And that formation starts to spread. And then from there, they're going to start creating what's called the medullary cavity. And then from there, we're going to have more growth take place. I'm not going to get you into too much detail about this, but this is kind of just an overall idea as to what is taking place. So we can see here that we start off with our cartilage model. And again, you have this collar around it called the perichondrium, and you see your cartilage cells in between. Cartilage cells get bigger, they start to calcify, they start to die. Now what's going to happen is, again, you're now going to start developing that periosteum. And then when we start developing this periosteum, again, we have blood supply coming in, we have osteoblasts coming to that calcified area, and they start to lay down this bone formation or bone matrix. And where this is occurring, we call this the primary ossification center. Now, like I said, you get more blood supply, more osteoblasts, you're producing this spongy bone. And then what's going to happen from there is we're actually going to have another type of cell come in called osteoclasts. So again, osteoblasts are bone-forming cells. Osteoclasts are the ones that are breaking down bone. So they actually break it down and they start to form what's called the medullary cavity. And so again, that's where we're going to find our red marrow and our yellow marrow. And then as this is spreading, now we're going to start working on the epiphysis. We start to work on those shafts. So we call this the secondary ossification centers. And there is still a little bit of cartilage that remains, a little bit of hyaline cartilage. And that's what we see here in this epiphyseal line. And we'll still see that epiphyseal line even after birth. This will continue until, again, that person reaches puberty. And usually by age 25, now these bones have fused over. And now we just see the epiphyseal line as opposed to the epiphyseal plate. So in terms of how I'm going to ask you test questions, I'm not going to ask you any crazy detail, but I do want you guys to know basically the difference between the intramembranous and the endochondrial ossification. But I would like you to know, again, what are some examples of intramembranous as well as endochondral bones. I'm not going to ask you to know step by step, but I would like you to understand sort of what is happening in each step. So again, knowing that there's mesenchyme that's going to be originally in the intramembranous, knowing with endochondral that's starting with hyaline cartilage, that those chondrocytes start to break down. And again, we have that periosteum develop, basically kind of understanding this little table here. Again, you won't be asked to put anything in order or in a sequence, but just sort of having an idea of what's going on in each step. All right, now we also have to think about the epiphyseal plate. So as I said before, that hyaline cartilage remains back. So when we think about that epiphyseal plate, there's still a little bit of hyaline cartilage, which allows for lengthening to take place. So we don't have bone growth or bone lengthening after age 25, but we do have something called bone thickening. So when we think about bone length, this is because of the epiphyseal plate. And so just so you know, there are 4 different layers of the epiphyseal plate. There's a resting zone, a proliferating zone, a hypertrophic, and a calcified. In the resting zone, this is where they're just sort of anchored there, and they're the closest to the ends. With the zone of proliferating, now they're undergoing mitosis, so you're going to have more cells present. Then you have a hypertrophic zone, and this is where the cells actually get bigger. They start to kind of calcify, and those chondrocytes start to break down. Then finally, in this calcified cartilage, it's a thin layer of dead cartilage and calcified matrix that allows for those osteoblasts to be able to go in and start actually forming bone. And so here you can see this picture in a lot more detail. So again, the ones that are closest to the epiphysis is your resting zone, just normal chondrocytes hanging out. Zone of proliferating, now they're multiplying, so that's when they're undergoing mitosis and going through that cell cycle. In the zone of hypertrophic, hyper meaning excessive, trophic meaning growth, they get bigger. And as they get bigger, these chondrocytes are going to die. Now, as they die, they're going to start to actually calcify. And so this is where, again, it allows for those osteoblasts to start coming in and starting to actually form that bone. So this is why, again, you're able to lengthen. And as long as that epiphyseal plate is present, the growth will still continue. This bone lengthening will happen. Once this epiphyseal plate has ossified, so again, we hit age 25, this is no longer going to allow for growth. Now, as I said before, we have to think about this epiphyseal plate in terms of osteoclast and osteoclast and osteoblast. Osteoclast are the cells that break down bone. We call it bone resorption. Versus osteoblast are the ones that are going to start building up bone. So when we think about that calcified matrix that we have from those chondrocytes that died off, we have osteoclasts that come down and actually break through it. Then what will happen is we have osteoblasts that are able to invade, and they start replacing those cartilage cells with bone. And again, the bone is going to continue to grow in length. As long as there is an epiphyseal plate, as long as there's a growth plate there and active, the bone will continue to grow. But when the ossification centers finally meet and the epiphyseal plate is going to basically become bone, there's no longer going to be bone length. Now, the bone can thicken, but it can't lengthen. Now, when we think about now bones getting thicker and growing stronger, they can thicken by actually depositing compact bone on the outside under the periosteum. So we can have some thickening going on. And this happens all the time, especially if you're someone that is more athletic or maybe you lift weights, you're going to have more of that thickening take place because of bone deposition on compact bone. But when we think about bone lengthening, it's because of epiphyseal plates. So this is just a timeline of sort of what is taking place. Like I said, this starts in the 3rd month of prenatal development and continues on until we are in our 20s. I do want you to sort of look though at what is taking place. So again, in the 3rd month, we have ossification and long bones beginning. Obviously, from birth to 5 years, we have those secondary ossification centers that are going to start being worked at. And it's because, again, of those epiphyseal plates. And then from 5 to 12, you're going to see a lot more ossification taking place. Now, depending on sex and depending on a lot of nutritional factors and some genetics, you're going to see that girls and females tend to ossify quicker. So they tend to have their bones fuse quicker, which can lead to some issues, especially like even if you think about like braces, that can potentially become problematic if the child needed braces earlier and didn't get it, versus not so big of a deal for boys. But from 15 to 18 years old in females, we tend to see the upper limbs ossify. For males, it's about 17 to 20. For the lower limbs and thinking about hip bones, it can range anywhere between 16 to 21 for females, 18 to 23 for males. And then usually again, when we start thinking about by age 25, nearly all the bones have completely ossified. We do have a little bit of growth within some of our facial bones, like in our nose. However, most of the bones, nearly all, are completely ossified by age 25. All right, so I hope that's starting to make sense so far. Next, we're going to talk about something called homeostasis. And this word should sound very, very familiar. We've talked about it before. It is the internal stability. So think about like that teeter-totter. We're always trying to maintain internal stability, whether it's blood pressure, pH, glucose regulations, and also thinking about our calcium. So bone remodeling constantly is happening due to calcium, and it occurs throughout life. Usually 20% of the skeleton is replaced each year. And the reason we don't notice this is because it's happening so frequently that we have a mixture of absorption or reabsorption and deposition taking place. But basically what's going to happen is with bone resorption, we're removing bone. If we're removing bone and breaking down bone, we're using osteoclasts. So again, osteoclasts help to break down bone. Versus for bone deposition, we are actually using this to make bone. We're forming bone. So we're using the work of osteoblasts. So basically homeostasis is just a balance between osteoblasts and osteoclast activity of whether or not we have this resorption or deposition taking place. And so there are factors that are going to obviously play a role in this bone formation as well as with growth and repair. So I first want to take you through the vitamins, then we're going to mention some hormones, and then we will actually talk about physical stress at the very end. We will talk more about all of these coming up very soon, now that we've kind of gotten out of the talking about like chemicals and cells. Now we're going to actually start mentioning of why these things are so important to the body. But vitamin D helps with calcium absorption, so essential. One of the things that we've noticed is that lack of vitamin D, so lack of exposure for sunlight. Again, maybe this is due to some issues with hormonal levels or nutrition, but mostly for sunlight exposure, it can actually lead to bone deformation as well as softening of bones. So rickets is very commonly found in countries in areas where there's lack of sunlight exposure. So those that maybe have been like sailors at ship and at sea, or maybe have been in a submarine, or again, for even what we've noticed for NASA astronauts, they have a development of rickets. Versus osteomalacia is the softening of bone. So again, it's just due to the fact that they don't have that calcium absorption, therefore they don't have that proper osteoblast activity, and they don't have that bone formation taking place. Vitamin A, we talk a lot about when it comes to our vision. We really tend to know about vitamin A and thinking about carrots in terms of being very beneficial. Vitamin A does a lot. It's very useful and essential for nervous system function, for cardiac function, and also for osteoblast and osteoclast activity. So lack of vitamin A, and this has actually been studied in third world countries, lack of vitamin A actually retards bone development. So especially like in areas such as Africa, they've noticed that the lack of vitamin A, not only is there issues with mental retardation and also issues with vision, but they've also noticed that there's issues with bone development. Now, vitamin C helps to promote collagen synthesis. Why this is important is your bone's extracellular matrix is composed of collagen. And if you have lack of collagen, you're not going to have the same structural integrity. So you're going to see more fragile bones. Next, we're going to start talking about hormones, and these will come back. We're going to make mention of these guys when we talk about them in the endocrine system. But growth hormone is number one. This helps to stimulate that cartilage cell division. So thinking about that work on the epiphyseal plates. So unfortunately in children, this can cause pituitary dwarfism if there's an insufficient amount of growth hormone, versus too much can lead to either giganticism or acromegaly with an adult. Now, the thyroid hormone actually helps to replace cartilage with the bone in the epiphyseal plate. So it helps to promote osteoblast activity. And this special thyroid hormone that we think about is actually called calcitonin. So it helps with osteoblast activity. And again, really in teeter-totter with the next hormone that we're going to make mention of, the parathyroid hormone. And there is a parathyroid gland, just like there is a thyroid gland, and the parathyroid gland produces parathyroid hormone. This one works in opposite. This helps to stimulate osteoclast activity. Therefore, we have bone resorption or bone breakdown taking place. So there's really this teeter-tottering back and forth between the thyroid hormone and the parathyroid hormone in terms of osteoblast and osteoclast activity. But we also see that sex hormones allow for bone formation as well. And they actually stimulate the ossification of those growth plates. So estrogen and progesterones are the ones to think for those. Now, something that we also have to think about too is not only do we have these vitamins and the idea of nutrients and hormone levels, we have to think about physical exercise as well. If you do not use it, you're going to lose it. So physical stress helps to stimulate bone growth. It helps with bone lengthening as well as bone thickening. And so when we think about bone thickening, that's essential that we have these sturdy and sort of tough bones. If you're not going to use it, your body isn't going to hold on to it. And so you will see that you'll have softer, fragile bones that aren't as sturdy, and they will break down under pressure. So physical stress is very much important for stimulation of bone growth. All right, next what we're going to do is we're going to talk about what happens if these bones break. Now, we don't technically call it a break. We will refer to it as a fracture. So there are multiple different classifications of fracture. But when we think about the two main classifications, we think about the cause and we think about the nature of the break. In terms of an open versus closed fracture, this is very easy to identify. So a closed fracture means that the bone did break, but it was broken and the skin was not injured in any way, shape, and form. So my son had a closed fracture. He was jumping on a trampoline and broke his leg, but there was no exposure. There was no open wound or anything like that. With an open fracture, this is actually like what happened to some of your NFL players just recently. If anyone knows, you guys can get extra credit. So if you send me an email and know what two, actually just recently, what two NFL players had open fractures, both of them were quarterbacks, if this makes sense. And I'll give you some extra credit, I'll give you a point of extra credit. And one still plays and one does not play at this moment in time. At least I don't believe he's playing. This is an open fracture. The bone is actually poking through the skin. So it is very easy to identify the difference between a closed fracture and an open fracture. If you see a bone push through the skin, that's an open fracture. And actually a good friend of mine as a kid, we were messing around and we knocked her sister off a bar stool and she ended up with an open fracture and it was pretty rough. So it's definitely something that you will know the difference between two. Like I said, a little extra credit if you can name the NFL players. Two just recently, one was last year, one was I believe the year previous, that just had open fractures. But here are some other types of fractures that you're going to see. So a green stick fracture is very common in kids. So what you'll notice is that the break isn't completely through. There's going to be a little piece that basically chips. And so what will happen is the convex surface of the bone basically bends. And so again, very common in kids that it's not a complete fracture. It's more of just a little break or a twig, hence the green stick fracture name. A fissured fracture is a fracture that goes longitudinally or in this vertical aspect. So it's not a cut across, it's basically a cut down. And it's an incomplete break that we see. With a comminuted fracture, this is where you're going to see bone fragments. So instead of having just a clean break where it breaks into two different pieces, you're going to see multiple little chips, if you will. And so it's little fragments of bone instead. So they call this a comminuted fracture. A transverse fracture is when you have a clean, complete break. So you now have two pieces of bone, and it's going to be usually straight across. An oblique fracture is going to also be where you have two complete pieces, but one will be on a right angle. I'm sorry, at an angle, not right angle, at an angle. And then a spiral fracture is one of the worst types of fractures because now you have, again, a complete break, but you now have that the bone itself had excessive twisting of the bone as well. And usually when we think about these types of fractures, we also involve ligaments and tendons to go along with it. So not only is there a break or a fracture, but there's also several other tissues that have to heal as well. And so obviously, again, if you had a closed versus open fracture, an open fracture is going to take longer to heal, more chances for infection, more chances for something going wrong. Versus if you have an incomplete fracture, you're more than likely not going to have those problems. And again, if it's a simple fracture or a closed fracture, you're not going to have those same involvements either. Now, when we think about the actual bone repair, there's a lot that has to go on. So remember that bone itself is very highly vascularized. So the first thing that's going to happen is you're going to see a very large blood clot accumulate, and that is called a hematoma. Toma means tumor, and hemato or hemo means blood. So this is just a giant blood clot that's going to reveal itself. And the reason is because blood actually escapes from these ruptured vessels. Again, you broke this bone, it has blood vessels, just like your skin would bleed, your bone's going to bleed, and it forms this hematoma. Then what's going to happen is you're going to produce what's called a cartilaginous callus. And so basically what's going to happen here is once that the blood has been removed, you also have different cells called phagocytes that are coming in to basically start removing that debris. And it's going to now be replaced with fibrocartilage. So if you guys remember, fibrocartilage is what we find like in our knee pads and between our intervertebral joints or intervertebral discs. And what they're going to do is they're going to start forming sort of this soft callus. So sometimes you'll call it a cartilaginous callus or a soft callus. And so you'll see that instead of having that hematoma, we now have this fibrocartilage coming through. But also what's going to take place is we're going to have new blood vessels actually starting to basically come to the area to promote tissue healing. Eventually what will happen is once that cartilage is there, we're going to have the basically replacement of the fibrocartilage take place. And instead we're going to have what's called a bony callus due to osteoblast formation. So the osteoblasts end up evading, and instead of having the soft callus, we end up with a hard callus, or what we call a bony callus. And then through the remodeling, we have osteoclasts come in and remove any excess bony tissue. We restore the new bone structure, and it's pretty much like the original, although usually you will see some sort of maybe line or scar. But basically it restores as close as it can to the original shape. All right, now we have to think about the function of bone. So there's major functions to the bone. Again, we kind of mentioned these before. They help to provide shape to the body. So we have a certain framework. They help to support our body structures and protect our internal organs. They also allow for that muscle attachment. So when you aid in body movements, again, it's because of the fact that they have proper muscle attachment that will take place. Again, instead of that spongy bone, we think about the production of red blood cells and other blood cells like white blood cells and platelets, and it helps us to store those salts. So when we think about the support and protection, again, this is pretty straightforward and easy. We want protection to our vital organs. We want the bones to actually support our body weight. And again, we want to be able to have movement along with those muscles. In terms of blood cell formation, this is where the term hematopoiesis or hemopoiesis takes place. Hematopoiesis is the formation of blood cells. And so when we think of blood cell production, this is occurring in the red bone marrow. So if you've heard of someone having a bone marrow transplant, again, this is the red bone marrow that we're thinking about for blood production. So in terms of blood production, we think of our red blood cells, We also have white blood cells, and we have platelets that are going to be produced there. We're going to have a whole chapter on blood, so just be prepared. It's kind of nice to sort of know this now because it may make your life a little bit easier coming in the next few weeks. But with age, some of that bone marrow actually gets replaced by our yellow bone marrow. And our yellow bone marrow functions to store fat. It does not produce blood cells, but it does help us to store our fat content. And then again, we have that storage of our salts. So the most abundant salt that we'll see is the hydroxyapatite, which is a calcium phosphate, but we have other salts as well. We have magnesium and sodium and potassium, and we need these in order to keep the bone hard. So unfortunately, what you can hear about is issues with bone mineralization or maybe lack of bone density. And this is going to be a condition called osteoporosis. So when we talk about osteoporosis, usually we tend to think about that they have more fragile bones. So sometimes you'll hear, especially it's very common in women over the age of 50 or that have been through menopause to actually have issues with osteoporosis. It's more common, again, it can happen in men as well, but it's more common to happen in females. And so what will happen is that with this bone remodeling, instead of having this balance between osteoblasts and osteoclasts formation, you have more osteoclasts that are removing bone than you do have osteoblasts depositing bone. And so it's very common that you're going to see problems within spongy bone. You really don't see it in compact bone, but you're losing spongy bone. So imagine, if you will, that you have this big, beautiful mansion and it looks gorgeous on the outside, but you never put any load-bearing walls in, or you never put any columns in. That house will fall apart from the inside. Same thing happens here. We end up seeing these issues with lack of spongy bone, and then it makes the bones very fragile. Now you can also see just true bone loss, which is osteopenia. And again, you can see osteoporosis, which is more severe bone loss that just really is going to weaken the bone. Now, you can't replace what's already gone, but one thing that you can do to prevent these structures is to actually have physical exercise. So no matter if the person is 22 or 102, having physical exercise and including weight-bearing exercises will help to prevent any bone loss from taking place. Again, calcium and vitamin D are also essential, and they've also noticed that high smoking or the risk of smoking also will increase that chance for bone fractures in this issue with osteoporosis. So some things to keep in mind. Now, when we think about our major ion when it comes to our salt storage, we think about calcium. Calcium is vital, and calcium is found everywhere and needed for everything. We need calcium for our muscle contraction. We need calcium for our nervous system function. We need calcium for blood clotting. Calcium is just essential in so many different areas. So what we have to do in order to make sure that in the homeostatic balance, our blood calcium levels are regulated, again, we use the parathyroid hormone and calcitonin. We use the parathyroid gland to produce parathyroid hormone, and then we use that thyroid gland to help us to secrete calcitonin. And so this is just a great little figure, you know, how we've talked about before with body temperature regulation and blood glucose levels. Same thing's got to happen with blood calcium levels. So if it's too high or too low, we'll see negative feedback responses occur. If blood calcium levels are too high, we're going to go to the thyroid and insist that it start increasing that will notice the sense of increase in blood calcium levels, and to basically say, release calcitonin. Calcitonin activates osteoblasts to start formation of bone. So instead of having calcium in our blood, it's now going to be transferred into actually making bone. Now, on opposite aspect, if our blood calcium levels are too low, we now activate the parathyroid gland to release parathyroid hormone and to activate those osteoclasts to break down bone. So again, there's this constant teeter-tottering back and forth. So for your test, I will definitely ask you to be able to explain osteoclasts and osteoblasts, as well as making sure to show in negative feedback, whether it be too high or too low. So be prepared to know this slide either way. All right, next thing that we have to keep in mind is the fact that we have not only this bone physiology aspect, we now have to start thinking about the structures of bone. So I'm going to leave this more for the lab portion, but just to be prepared, we have 206 bones in the body to keep in mind. We have 80 in the axial skeleton, and we have 126 in the appendicular skeleton. So to see how this breakdown takes place, I think this slide is very useful to kind of get you in the mind of what to expect. Now, for the lab exam portion, you're not only going to be looking at these bones, we're also going to be talking about bony structures as well. Now, keeping this in mind, I do want you to know what are the divisions. So axial skeleton is going to be 80 bones, appendicular will be 126. For the axial skeleton, it consists of your skull, your middle ear bones, the hyoid bone that actually sits underneath the mandible, the vertebral column, and your thoracic cage. Versus the appendicular skeleton is going to be more of the appendages. So this will be like, for instance, your scapula. This would be your humerus, your radius and ulna, the pectoral girdle, the limbs of the upper extremities, your pelvic girdle. So thinking about the hip, and then thinking about those lower extremities. So the femur, the patella, the tibia and fibula, and your tarsal bones. So definitely want to make sure you know where those fit. All right, that's all I have for you guys for today. The next step is to go look at the lab exam or the lab exam slides and to be able to review those. If you have any questions, please let me know. Otherwise, have a wonderful day.